Hello, and I'd like to welcome everyone to Grand Rounds for the Minnesota Regional Spinal Cord Injury Model Systems, or as we call it, SCIMS for short. Thank you all for joining us today. The Model Systems is funded by the National Institute on Disability, Independent Living, and Rehabilitation Research, or NIDLR, to support innovative projects and research in the delivery, demonstration, and evaluation of medical, rehabilitation, vocational, and other services to meet the needs of individuals with spinal cord injury. SCIMS represents an exciting partnership among the following Minnesota institutions: Courage Kenny Rehabilitation Institute in Minneapolis, Mayo Clinic in Rochester, Regions Hospital in St. Paul, and the University of Minnesota in Minneapolis. Our community collaborators include the Minnesota Spinal Cord Injury Association, Unite to Fight Paralysis, Get Up, Stand Up to Cure Paralysis, the Paralyzed Veterans of America, the United Spinal Association, and the North American Spinal Cord Injury Consortium. This system collectively provides a multidisciplinary continuum of care for people with spinal cord injury, including medical, acute care, acute rehabilitation, and post-acute services. My name is Dr. Kimberly Mondin, and I will be the moderator of today's session. I'm an assistant professor in the Department of Rehabilitation Medicine at the University of Minnesota Medical School, and I'm co-project director of the Model Systems with Dr. Leslie Morse. A few housekeeping notes for today. So we have organized the CME for today's webinar. Please see the chat for information on how to record your attendance and claim CME credit for attending the webinar within 24 hours of the event. The meeting is being recorded and will be posted on the SCIMS website. Due to the number of registrants for today's webinar, we have placed phone lines on mute to reduce audio feedback. However, we welcome and encourage audience participation using the Q&A function. If you have technical or logistical questions, we ask that you please submit those in the chat to Dan Kelly. We would also like to thank all the people who work behind the scenes to make this Grand Rounds possible. The title of today's presentation is One Institution's Efforts to Address Disability-Specific Medical Education. The speaker for today's webinar are Drs. Michael Stillman and Nethra Ankam. Dr. Stillman is a professor of internal medicine and rehabilitation medicine at Thomas Jefferson University. He has a niche practice caring for people with chronic disabilities. Dr. Ankam is an associate professor of rehabilitation medicine, also at Thomas Jefferson University. She's involved with medical education at the medical school and university level through interprofessional education. We'd like to extend a welcome and also to thank you for presenting at today's Grand Rounds. And I will hand it over to Dr. Stillman and Dr. Ankam.
All right, thank you for that. We can go to the next slide, if you would. So first of all, Nethra and I are very delighted to be able to chat with you all today, and I'm particularly delighted because Leslie and I go back many decades. We were residents together at Boston University, obviously in different departments. I was in internal medicine and she was in rehab medicine, but we have a very long-standing friendship, and she's been, even though we're contemporaries, one of my most important mentors and teachers over the years. So I'm very happy to be able to chat with Leslie and her faculty today. Nethra and I really wanted to talk to you about disability education. And, you know, obviously the topic of spinal cord injury and improved care of the folks living with spinal cord injuries come into this, but it's really part of a bigger discussion about disability education. And so we thought we'd start by framing the problem. So as you all know, a quarter of adult Americans are living with a disability. That means that 25% of us have a limitation in at least one activity of daily living. There are people with more obvious or complex disabilities. As you know, 1.5% of the American population uses wheelchairs as their primary means of mobility in the community. 6.5 million Americans have intellectual and developmental disabilities. Nearly 1 million Americans each year have strokes. Some people recover quite nicely from them. Some are left with functional limitations and disabilities, and about 300,000 Americans are living with spinal cord injury. So, you know, what we see is this picture where some people have rather complex and specific medical care needs. And some people might not have very complex medical care needs, but are left with needs for home and community-based services or interactions with therapists. And in all cases, physicians, non-physiatrist physicians, and to my particular concern, generalist physicians and primary care docs are poorly equipped to be able to help provide those medical services to people with disabilities. And why is that? It's because very few medical schools and residency programs, again, outside of PM&R residency programs, provide disability-specific education to their learners. Next slide. And that educational dearth has real clinical consequences for people living with disabilities. So there's a relatively robust literature documenting that even now, more than 3 decades after passage of the Americans with Disabilities Act, American healthcare facilities remain woefully unacceptable to people with disabilities, particularly our outpatient healthcare facilities. There's some literature documenting lack of preventative services for people with disabilities. Next slide. Various authors have looked at this in the spinal cord injury world. Sherry Lavella did a very important study on this in 2008, looking at how women with spinal cord injury don't get the cancer screenings and preventative services that they ought to. This study was put out by Leighton Chan now over 20 years ago, but I think it remains very current and important and very true. So he had access to the medical records of several thousand Medicare beneficiaries. He was able to glean in how many activities of daily living they had limitations, and he was able to describe an inverse correlation between receipt of preventative services and the number of ADL limitations, particularly affecting women, such that women with a greater number of ADL limitations receive significantly fewer pap smears and mammograms than did women with fewer ADL limitations. Next slide. We know that there's a literature documenting lack of physician knowledge around the care of people with disabilities. So I think the most poignant of these articles was written by Elizabeth Morrison, I believe in 2008. She interviewed community dwelling people with mobility disabilities about the health care that they received. This was a qualitative study, and many of her participants reported having to teach their physicians how to care for them, which ought to surprise none of us. There's a persistent physician inability to think holistically about disability. So I think in the absence of kind of smart and robust disability education, many of us are stuck with this medical model of disability, where disability is stigmatized and seen as something to fix or correct or cure, rather than having us employ the biopsychosocial model of disability, which looks really more the interaction between an individual and her environment, and looking at environmental limitations to having her be as functional and independent as possible. And then finally, we have this article by Lisa Iazzoni. Next slide. And I don't know if any of you have read articles by Lisa Iazzoni. She's got a long history. She's at the Harvard School of Public Health, and she came out with a real blockbuster a couple of years ago. If you haven't seen this article, you should look it up. So she surveyed over 700 practicing physicians. About half of them were primary care docs and half of them were specialists. And she inquired about their perceptions of the care of persons with disabilities. And there's a lot of data in this article, but I think these are the real take-home points. So first of all, only 80% of her respondents said that it was important to understand people with disabilities. Under 18% of her respondents strongly agreed with the statement that people with disabilities are treated unfairly. And I think any one of us on this Zoom call understands that people with disabilities are not treated equitably in the United States, and particularly in the healthcare space. Only 40% of her respondents were very confident in their ability to provide equitable care to people with disabilities. And then that third number over, I think, is really kind of the take-home point. Over 80% of her respondents said that they perceive that people with disabilities have a poorer quality of life than do those of us who are not living with disabilities. And I think we can all easily imagine the biases that introduces into our care. Like, if we really believe that our patients don't have much of a quality of life, how motivated are we to give them thorough and comprehensive care that we would all hope and expect to receive? So it's in the background of this that several institutions across the country, although really only several, are beginning to struggle with how to improve disability-specific education, both at the UME and the GME level. And we wanted to chat with you about what we've been trying to do at Jefferson. Nethra is going to talk first about what she's been doing mostly at the UME level. She's really been a hero at our institution in spearheading a monumental effort, pretty much in her free time, which is very little. And then we'll talk a little bit about what we've been doing in the internal medicine residency program, and then we'll open it to discussion. So Nethra.
Thanks so much, Mike. Like Mike was saying, I am involved at the medical school level. You can go to the next slide, please. So I have a role as wellness thread director, one of the 12 threads that goes throughout the whole curriculum, and I'm also involved in interprofessional education. But this allows me a platform to push for disability education. So SKMC, Sidney Kimmel Medical College at Thomas Jefferson University, is a large urban private medical school that underwent a complete curricular transformation 6 years ago. And the centerpiece of this revised curriculum is case-based learning. So they took a curriculum that was traditionally 2 years of preclinical and 2 years of clinical and made it 18 months of preclinical work, and took away, full days of lecture to include case-based learning. That's about 4 hours a week, and they have a smattering of lectures to support that and a lot of small group work. So they really changed the way we do things. But and each week has a case where the students work through the case to develop self-directed inquiry questions to guide their learning. And it's supported by 10 hours of lecture a week and weekly quizzes to gauge their learning. But despite this complete transformation, there was still lack of disability representation in the curriculum. And so this is my story of how I'm trying to change that. So next slide. So first, when you're trying to change anything, you need to obtain buy-in, right? And so you need that ally who knows the ins and outs of the curriculum. And that was me in this case. So I was aware of efforts after the George Floyd, aware of efforts to conduct a lens analysis from the view of race and racism. And so I thought, with some prodding by Mike and Steve, to ask for permission to review the curriculum preliminarily from the lens of disability. When we think about that graphic that I just showed you on the previous slide, there's not a lot of time, and every hour is precious. So and every day, the deans of curriculum get requests for inserting more curriculum, and there's not enough hours to do that. And so their reflexive response is no. But luckily, because I have been so involved in the curriculum, they were okay with me doing this and taking a look, because they knew I was not going to say, let's add 100 more hours of lecture or something that would not feel doable. So I presented that gap analysis formally to the curriculum committee with the request to conduct the lens analysis. Next slide. The results of my gap analysis were that I found few representations or mentions of disability, did not find representations outside of the biomedical model, found some harmful stereotypes where disability was equated with morbidity and mortality, but did note that students had contact with people with disability through interprofessional programs and patient panels. And this is very typical of most medical schools. So it wasn't surprising to me. Thankfully, there were not too many instances of very harmful language, but that still needs to be, still needed more analysis. Next slide. So we actually did a qualitative analysis of all the cases and coded the cases for disability concepts, including critical disability theory type concepts. And disability was only mentioned 4 times in the 53 cases. They were mainly in the facilitator prompts and mainly related to the biomedical model. There was no person with disability in the cases who happened to have an unrelated complaint. Next slide. So our charge from the curriculum committee was to lead a disability task force to conduct a lens analysis of the curriculum and provide recommendations. And so we did that, and I'll talk about how we recruited that task force. Next slide. Our biggest goal was first to have a community advisory board. The rallying cry of the disability rights movement is nothing about us without us, and we wanted to make sure that we embodied that. So we had a goal to reach as many people as we could with different types of disability. Despite that outreach, we were unable to recruit those with sensory disability, but we did have people with who represented community organizations that enhance community integration of people with intellectual and developmental disability, in addition to people with physical disability. So we had representation from our local Center for Independent Living, and then the ARC of Philadelphia. So we at least had that representation. We also involved students, and we had a lot of students who were interested. We ended up taking everyone, but we had them apply. So we saw that they were invested in this process. And we had all 4 years represented, which was amazing. We also intentionally had diverse representation throughout the medical school of the faculty. So the chair of the curriculum committee was on this task force, who is also the case-based learning director. We had the health system science thread director, the clinical skills thread director, the internal medicine clerkship director, the director of the Jefferson Fab Center for continuing care, and then primary care physicians who had focus of care of people with disability, and then rehabilitation medicine physicians. So we had a really great group to work through this. And this process was also supported by a curriculum retreat on disability. Next slide. So we did a literature review, didn't find too much in the literature about longitudinal integrated disability curriculum. We also had a 3-part virtual retreat that involved many members of the SCIMS community, that included the provost, the curriculum committee, faculty and students from all levels, and disability task force members. And during that curriculum retreat, we set the stage. We provided some of the information that you just heard from Dr. Stillman earlier, and talked about a little bit about diagnostic overshadowing and ableism, talked about systemic biases in medicine from a perspective of a physician who uses a wheelchair, the disability, and then the relationship of disability in medicine, and some concepts from critical disability theory. We also had first-person narratives of people with disability and their experiences with healthcare, which were very affecting and very important to hear. The second part of the retreat was brainstorming sessions that included a curriculum committee member, a faculty member with expertise and in disability care, and a member of the disability community. And they were given particular prompts regarding communication, clinical skills, ableism, and bias. And then we had a summary session with the recommendations. Student task force members also conducted in-depth interviews with our community advisory board. We reviewed the medical education program objectives. Those are the guiding light of a school, and everything gets mapped to them. So we made some suggestions for those medical education program objectives to include disability. And we identified some other objectives that are important but did not need revision. We also reviewed the components of the curriculum for opportunities to include disability, and used a lot of the suggestions from the curriculum retreat. We mapped those suggestions to the MIPOs, because everything needs to be mapped, and assessed for gaps, developed an assessment strategy, and then reviewed the draft report with the community advisory board and incorporated their suggestions. So they had several opportunities to provide input. Next slide. I want to just go over some of the suggestions from the community advisory board that really were our guiding light. And when you read these suggestions, they're basically asking for good medical care. You know, they want healthcare professionals to communicate in concrete, scaffolded ways regarding medical tests, physical examinations, and procedures, and include exploration of communication and learning styles. Ensure persons retain their autonomy, are spoken to directly, practice alternative ways to obtain information, understand the roles of the people in the room, and how they're supporting the patient in what capacity, understand concepts of supported decision-making and shared decision-making, understand that there's a dignity in the right to risk, and we need to understand that concept and not be overly paternalistic with our patients. Practice trauma-informed care approaches, given the prevalence of medical trauma, and to understand previous experiences that impact current situations. Understand the coordination of care and other healthcare professionals and with other healthcare professionals and medical specialties, as well as understanding how to coordinate with the individual's personal support network. understand how to advocate for healthcare related issues, including such as understanding the home and community-based systems, such as the Medicaid waiver programs and other resources in the community. Ensure awareness of intersectionality with disability and other identities and how that impacts that experience of disability. So how does having a disability interact with being undomiciled? How does disability interact with pregnancy? Will bias prevent that disabled person from caring for their child? And so when we're talking about other identities, talk about disability. Next slide. We wanted to prevent diagnostic, they wanted us to prevent diagnostic overshadowing and anchoring bias, meaning that they didn't want every new problem that they had attributed to the disability. This actually comes out of the mental health literature, where so many problems were then attributed to their mental health issue. Like, for instance, I always reach for this example because it's my friend told this to me and it was so evocative. He had a patient, he's a psychiatrist, and he had a patient who has schizophrenia who complained of having muskrats in their throat. The ED was like, oh, schizophrenia, this is a delusion, sent to the psych floor. A couple days later, he's like, she's still complaining of muskrats in her throat. And he then looked at her throat and she had strep throat. So that was an example of diagnostic overshadowing where the mental health condition prevented further exploration of a person's health problems. Recognition of implicit bias regarding quality of life, which Mike alluded to earlier, and recognizing our own implicit bias, practice perspective taking, asking patients about disability, thinking about how a person's life and goals change over time and how does the team adapt to help that person. What do we do when the whole team's not available? Understand how to use interpreters, including sign language interpreters and other accommodations. Understand infrastructure requirements such as scales, tables, bathrooms, ensure appropriate sex education, and don't allow bias to prevent referral to GYN or STI testing. And always mention sensory, physical, and intellectual disability together to prevent any one stakeholder from being left out. Next slide. So with that in mind, and through that robust process, we developed some curriculum recommendations. So we asked them to form a task force to study our proposed MIPO changes and decide what to adopt based on the broader context of the curriculum, provide clinical and communication skills training to our students to care for those with disability, evaluate disability representation in the curriculum to address bias, stigmatizing language, stereotypes, and negative attitudes, teach students foundational knowledge and skills to advocate for people with disability. We asked them to strongly consider developing a 2-week required rotation in disability care or chronic care. And that really came out of this idea that we can tell the students all of these pieces of care that are needed, but if they don't see it in the clinic, then maybe it won't make as much of a difference. So when we think about the cases, we think about much of medical school curriculum tends to be focused on the acute issue, the acute problem, starting from an able to baseline. So a required rotation in settings where functional, goal-based, chronic, interprofessional care is provided would be useful to show the students that the needed information that we had taught them earlier is actually used in clinical practice and how it might be used in clinical practice. We do have an elective in disability care that I'll talk about later, but we wanted it to be required. Next slide. We also wanted them to have so some examples of clinical and communication skills training is physical examination skills, adaptations for impairments, and understand how to make the environments accessible, communication adaptations for impairments, trauma-informed communication, questions regarding functional status and activities of daily living, simulated and real-world practice would be needed, and understand models of decision-making. Next slide. So we gave them examples of things that would be low resources short-term, high resources medium-term, high resources long-term. So some things might be as simple as including some extra questions about disability identity in patient panels and decision-making and language. Something more high resource would be creating communication sessions with people with disability, focusing how to interact with people with disability and their team. And something more long-term would be recruiting more standardized patients with disability and using them for both disability and non-disability related sessions. Everyone can have abdominal pain or need an abdominal exam, right? Next slide. And then we wanted to make sure that we had examples of how to address disability representation and bias. So ensure disability is mentioned when other minority groups are mentioned in lectures, create a guidebook for faculty for appropriate language, evaluate and repair case-based learning cases to include disability where it is a demographic characteristic, concept of diagnostic overshadowing, and remove biases, where at least we talk about how disability is often equated with death or poor health outcomes and how that is stigmatizing, and then create opportunities for advanced discussion of these topics in the clinical years. When we're talking about teaching foundational knowledge for advocacy for people with disabilities, so we want to understand the resources available for patients, create and look at transitions of care, evaluate clinic spaces for accessibility. Next slide. We had a couple other recommendations about faculty development, having a standing task force, and further assessment of clinical settings. We actually got most of our recommendations. Next slide. Sorry. Those were the other recommendations. And then the next slide. So our accepted recommendations were to form a task force for the study of the proposed MIPO changes and decide which to adopt. Provide the clinical and communication skills, evaluate the disability representation in the curriculum, teach the students the foundational knowledge, the student assessment strategy, and faculty development. So they did not go for that required rotation, but we were able to get a lot of these recommendations that we wanted, which then provide a scaffolding to create a lot of different curricular interventions. So next steps, this is the next slide. So we created a repair kit for the CBL cases. We've been repairing those cases. We actually have had several cases where disability is an identity, and they've been able to have these discussions. We're working on additions to the clinical skills portion of the curriculum in the sense of how do we universally design the physical exam for patient comfort. And so there'll be a new patient comfort section that will include issues of accessibility and issues of trauma-informed care. We're also in the process of creating a lecture guide to help lecturers understand some of the terminology they shouldn't use and some of the terminology they should use. So all of these efforts are ongoing. Next slide. Our one thing that we do have that even before this is we have a care of people with disability elective, which has been very popular, filled the entire year, 2-week elective partnership between family and community medicine and rehabilitation medicine, where they have 4 days at that Jefferson Continuing Care Clinic or Jefferson Fab Clinic, 3 days in PM&R outpatient clinic, a day in ALS clinic, and 2 days on inpatient central nervous system consults. And you'll notice that these objectives for the objectives for the undergraduate medical education curriculum as a whole have really been about communication and physical exam and accessibility and coordination, because if they don't have those essential skills to be able to get the knowledge, they're not going to be prepared for internship when they have to be able to take a history and physical from any person going forward. And so my efforts have really been focused on making sure our students understand how to communicate and examine people with disability. So now I will turn this back over to Mike, where he'll talk about where that knowledge comes in for caring for people with disability.
Oh, good. Thank you. Something I forgot to put in this slide deck, by the way, is that a couple of years ago, we approached the internal medicine clerkship director and told her that we wanted a required lecture on the care of people with spinal cord injury. So now everybody who does the IM clerkship at Jefferson gets one lunchtime lecture on secondary conditions associated with spinal cord injury. So at least that. When Steve and I first came to Jefferson, and then really a couple of years after, we put together a committee that Nethra chairs, unsurprisingly, called the Educational Innovation Committee. And it was an interdepartmental committee, so mostly, obviously, with representation from PM&R. But I was there from internal medicine, then Mary Stevens, who's our colleague in family medicine, who does a lot of work with folks with intellectual and developmental disabilities. Mary and I have secondary appointments in rehab medicine. Got together and we were thinking about not only how we can help one another in the research and academic space, but also how we can begin to answer fundamental questions about disability education. and improvements in clinical care. And one area that we were all kind of concerned with is how primary care docs of the future or generalists are being trained or not trained to help care for people with disabilities. And so we developed a survey around that, and we distributed it to internal medicine and family medicine residents in a select group of residency programs in the Northeast, both allopathic and osteopathic. And we asked the responding residents to describe their own level of comfort in helping identify and manage common coexisting conditions. And these were their answers. And you can see that very few of these residents, and by the way, their answers were not determined by their level of training. So the interns' answers were exactly the same as the PGY3s. Very few of these residents felt comfortable identifying and helping manage a lot of common coexisting conditions. Next slide. We also asked them about their level of comfort in helping identify their patients' needs for home and community-based services. And I want to be clear about this. We didn't ask them about their level of comfort in providing home and community-based services, but just about identifying their patients' needs for them. And you can see again that very few of these residents felt comfortable identifying their patients' needs for mobility devices or durable medical equipment or home adaptations. The numbers at the bottom part of the slide maybe surprised us because, I have a niche practice caring for people with disabilities, but most of what I do is just kind of like regular bread and butter primary care. And in that capacity, I rely very heavily on my relationships with the occupational therapists and speech and language therapists and physical therapists at Jefferson to provide our patients the kind of comprehensive care that they need and deserve. Very few of these generalists in training understand the scope of practice of the different types of therapies and how to coordinate care with therapists to get our patients kind of the bang up care that we would like to be able to provide them. Next slide. We more recently asked this question from a different vantage point. We went after program directors, and I'll tell you that these data are kind of under review right now. So this is kind of a cone of silence moment. Don't tell anybody I shared these with you. But we through a very difficult process, like getting through the eye of a needle, got a list of 104 program directors of primary care internal medicine training programs or dedicated primary care tracks within more traditional categorical internal medicine training programs. And we developed a survey about the disability education that they are or not providing for their residents. And again, these are program directors who are specifically running primary care tracks, so people who are turning out mostly primary care docs. Of those 104, 46 responded, so our response rate was about 44%. And I nudged them relentlessly, but even then, under half of them responded. And so look at this, of those 46 people who responded, only 13 of them provide any disability curricula or education to their residents. Only 8 of them said that disability curriculum or curricula are required. The other 5 said that it's optional. And when we asked them which topics they covered, well, most of them covered community resources that are available to people with disabilities, but far fewer taught their residents about patient-centered communication or considerations in the care of people with intellectual and developmental disabilities, social determinants, specific impact on people with disabilities, or common coexisting conditions. So what we found is that even among program directors training future primary care docs, very few of them are providing disability education. And when they do provide it, it's very shallow and thin. Next slide. We also asked them about their perceived barriers to providing more disability education to their future primary care docs. And you can see that the most popular answer was lack of time in the curriculum. That's not a surprise. But right behind that came lack of expectation by the ACGME and ABIM that physicians know anything about the care of people with disabilities. And I think that this is true. When you look at ACGME expectations, they don't mention disabilities at all. Certainly, I've taken the ABIM recertification exam for internal medicine twice, and I'm about to take it next year. I've never been asked a question about a person with disability. So I think if you're a program director and you're kind of teaching to the test, why would you teach your residents about the care of people with disabilities? They're never going to have to know it, although obviously they do. Next slide. So we started grappling with how we could begin to correct this. And we decided that we were going to develop a novel concentration within our internal medicine program in the care of people with disabilities. So our internal medicine residency program has a track in medical education and one in hospitalist medicine. And they're developing a couple of others, but we developed a third one in disability care. And obviously we had great input from Mary Stevens in family medicine and from my friends and colleagues in rehab medicine. And we went to the program directors in IM and we said, we want to do this. They gave us the green light. And we had Some overall goals for developing this track. First, we wanted to educate participating residents. So those are the residents who do this 2-year longitudinal track in the clinical care of people living with disabilities. So not to turn them into physiatrists, they're never going to be that, but to be able to have them be more meaningfully contribute to the care of people with disabilities and help co-manage their conditions and understand their care needs. We also wanted to prepare those residents to go out into their future workplaces and to be champions. Like, we wanted to turn out a bunch of Nethras and kind of like, send spores around the country so that other institutions can benefit from their knowledge and their interest in the care of people with disabilities. And then we also wanted to provide disability-specific education to the entire residency program. So even if we have 1 or 2 residents a year who do this track, we said every resident who comes through our internal medicine program ought to have a baseline level of knowledge about the care of people with disabilities. Next slide. So we went to the chief residents and we negotiated that we get 4 lunchtime lectures a year, which are the resident education sessions dedicated to the care of people with disabilities. And these are some of the topics that we've been giving them. We kind of picked 101 level, high yield topics. And we figure that if by the end of their 3 years in their internal medicine residency program, they've seen 9 or 10 of these lectures, pretty good. We also, by the way, developed an online lecture series that has, I think, 26 lectures, a more extensive list than this that's available on our Jeff Commons website. So the residents and people at other institutions can always Google that and get those lectures. And they're mostly between a half hour and 40 minutes. Next slide. For the people who are going through that 2-year longitudinal concentration, we also had specific goals. Next slide, I'm sorry. We wanted them, first of all, to understand the principles of hospitalization and acute rehab in the setting of disability. We wanted them, again, to be able to develop basic clinical skills in the co-management of people with a variety of disabilities. And we really wanted them to be able to understand the care needs of people with disabilities over their entire lifespan. And I'll tell you how we did this. Next slide. So they have a required 2-week rotation, either during 2nd or 3rd year, where they rotate through a variety of outpatient clinics. So they spend time with Nethra. Nethra does general rehab, but also does a lot of kind of seating evaluation. She works a lot with people with amputation. So she's got a very broad-based practice. They spend time with one of our other faculty members who does a lot of work in acquired brain injury and spasticity, but also some general rehab. They spend a day in the ALS clinic. They spend time with our neurourologist. They spend time with me doing primary care for people with disabilities, and also with our friend Mary Stevens in family medicine. So they learn a lot about the care of people with intellectual and developmental disabilities. They have a required 2-week inpatient experience. One of those weeks is spent at McGee Rehab. In the morning, they round on the inpatient service, and in the afternoon, they spend time in the outpatient clinic with a physiatrist there. And the other week they spend on our inpatient rehab medicine consult service. And our goal for that week is not to have them do consults as physiatrists, but really to start thinking about the care of people with disabilities in the hospital and how we can improve it and make it more patient focused and patient friendly. I'm sure you've all seen folks with disabilities on the internal medicine service who don't have needed equipment, who don't have caregiver support, whose nurses are refusing to do bowel care on them, saying it's not part of the scope of their practice. So, thinking about how we can make the inpatient setting a more safe and friendly place for them to seek care. They also have a required 1-week outpatient experience with Biata Home Care. So Biata is an international organization, but they're headquartered in Philadelphia. So during that week, they spend a lot of time with nurses and social workers, some at the home office and some out in the community. They attend a discharge planning meeting to understand about transitions of care between rehab and back to the community. They do home visits with medically complex patients and learn something about home adaptations. They spend some time in the office learning about insurance considerations in the setting of disability and how internists can help coordinate outpatient and community-based care for folks with disabilities. And then we have a series of required meetings with leaders both at the Jefferson campus and the community, where the residents just go pick these folks' brains. So we have them meet with the head of the Philadelphia Centers for Independent Living. We have them meet with the vice president of discharge services and planning. We have them meet with an ER doctor who runs our telehealth program to pick his brain about how to leverage telehealth technologies to improve the care of folks with disabilities, particularly people who have a hard time getting into our Center City campus. And then we also have them do an asynchronous online life care planning program with MJ Mulcahy, who developed that program. And I'm sure many of you know her. Next slide. And this is what that looks like. So again, this is spread over the 2 years. It's mostly asynchronous, so they can do it when they're not really getting nailed in the hospital and in the clinic. And They have to do at least the first year of this. They can also choose to do the second year of it. I pay their tuition from an academic slush fund, so it's cost-free for them. And you can see initially they learn about universal design, adaptive driving, home assessments, and legally required adaptations for people with disabilities. In that second half of the first year, they learn about a variety of disabilities, many of which they won't have seen during their inpatient and outpatient rotations, with a real focus on the etiology, the outcomes, and the treatments. And then if they choose to do that second year, that's where they really learn to anticipate care needs and cost needs over the lifespan of somebody with a disability, and how to write a life care plan, so that at the end of this 2-year course, they can sit for the national exam, they can become a licensed, certified life care planner, and they can bring an additional skill set into the workplace of the future with them. Next slide. So, there are challenges and opportunities to this work. First of all, and I think, Nethra is well prepared for this. I don't think she has many challenges. There's a process of continuous improvement process. How can we improve the UME level disability education? How do we assess the impact of that education? Nethra has already been working with some of her medical student mentees to develop assessment strategies around that. At the GME level, I think it's more challenging for a couple of reasons. First of all, a lot of the residents aren't particularly interested in this, and even just making that case to them that they ought to be more interested in this, and not just primary care track residents, but if they're going into gastroenterology or cardiology, they still ought to know something about the care of people with disabilities, and can really develop that as a niche clinical and academic focus. So that's been a little bit of a hard sell. How do we disseminate this across not only our own institution, but other institutions? We've thought about, how to make sure that every fellowship program and every residency program at Jefferson includes appropriate disability-focused content. I don't think any of us has really figured that out yet, but I will also tell you that at the national level, we've had great problems engaging other internists in this subject. We did present some stuff at AFTM about 1.5 years, which is the meeting of the program directors of internal medicine, but largely the internal medicine journals and departments of internal medicine still don't find this to be a particularly interesting or important topic, which has been a grave disappointment that my colleagues and my people don't really get this. And then finally, how do we make sure that these educational efforts really result in improved clinical care and access to care for people living with disabilities? And I think, that's the long work and the long struggle. So, we really want to talk to you all about this, and we want to hear your thoughts and questions. And the real reason is because what we found is that just as Nethra has been the champion at Jefferson, what few champions there are around the country seem to be either kind of PhD prepared researchers who work in disability care and disability education, or physiatrists. They're definitely not primary care docs. So we wanted to understand your perspective and kind of understand what's going on at your institution and how you think we could collaborate.
So with that, I will invite people to put questions or comments in the Q&A. Well, first of all, thank you guys for a great presentation today, a lot to think about. So as I mentioned, I think before this presentation started, I'm a psychologist. I'm part of Division 22, which is Rehabilitation Psychology of the American Psychological Association. We have a lot of members in Division 22 who have physical disabilities, who are strong advocates in the disability community and give amazing presentations on ableism, disability identity, disability pride. I just wonder how presentations like that might be received at some of these medical conferences. Like if you had, as opposed to coming from, somebody without a disability, if you bring in people with disabilities to be sort of the champion of the cause, if that would be something that would be well received.
Nethra?
Personally, I think it's always better received from the lived experience of somebody. I think that, one of the things is that I think there is a lot of crisis of identity that comes with learning about ableism. And because I remember when I first learned about ableism, I literally had to close my laptop and walk away because I was like like, have I been not taking care of my patients properly all these years? And that like gets to the core of who I am, right? And so so I think I think that it needs to include lived experience. And I think it also needs to acknowledge, like, whatever education we do needs to acknowledge that this might be uncomfortable and this might challenge our self-concept, you know, to think about some of these things, but it's so needed. And that was like, when I did introduce this information at the curriculum retreat, I came from that perspective because I knew it was hard for me. So I assumed it would be hard for other people to hear. And if I could disarm that initial defensiveness, maybe I could get them to talk. But I think that when you have people with disability presenting this information, it's always better than people without disability.
I don't see a question right now, so I'm going to continue asking you questions. Are you guys evaluating the program that you've implemented in the undergraduate medical education?
So we're still working on implementation, right? So I think what's difficult is that in a lot of education research, you have like a pre and a post test, and you have like a single session, right? And single sessions seem to change attitudes for that single session time, and then they go out the window, right? And so our thought is if we are putting small aliquots, we also have some dedicated sessions towards disability where people with disabilities speak about ableism, speak about their challenges with accessing healthcare, speak about their lives outside of being a consumer of healthcare, and some sessions on like disability identity and things like that. But if we can pepper their case-based learning and their clinical skills sessions where they're always thinking about people with disability at some level, we're hoping that it would stick more. And so we are doing some attitudinal surveys, like pre and post some of these things, but it's like one of those items that I'm not sure how to fully evaluate other than either OSCEs that involve people with disability in the OSCE, so that like we're actually seeing what they end up doing, or like consumer or patient reviews of, you know, people, because that's like your ultimate outcome. So this is why evaluation is so challenging, and we're still thinking about it and working through it.
You know, Nethra, I'd never considered this until you just said that, but it seems like, to use your language, by putting small aliquots of disability content throughout the curriculum, that in itself must kind of like normalize or destigmatize disability, because it's not like you just have one OSCE with somebody with spinal cord injury and autonomic dysreflexia. It's just kind of always there in the pond that we're swimming in. I really like that.
Right, which is the clinical milieu in which we work, right? So, so just hoping that they don't see it as a special topic that other people deal with, right?
Would your surveys around comfort with some of these topics not be one way of evaluating the impact of your education program?
So in terms of the undergraduate medical education program, we're not actually focusing on knowledge. We're focusing on skills and communication skills. So some of the pieces about comfort around spasticity management, or like, we're not teaching them that. So so then it becomes either direct observation of skills, or self-reported attitudes or self-reported comfort with maybe having a conversation with people with disabilities. So I think this is like one of the inherent challenges of education research, you know?
I wonder if we have any of our trainees on the call, or anyone from the PM&R medical student special interest group. Not to put anybody on the spot, but I'd love some perspective on how to, first of all, fantastic, amazing talk. Thank you so much. I'm hoping that maybe we can link to some of your resources. So after this talk, I'd like to go and kind of take a look at what you have publicly available, and we can try to promote and amplify that through our website and some of our postings. So really excited to do that. And then I agree that difficult conversations, particularly around expansion of skill or introspection around participation in some of these processes is so challenging, particularly in medical education. And it almost needs a very high level of facilitation to be able to move those conversations forward. But again, deeply immediately needed. And I'm hoping that you two will be national leaders in moving this conversation and dialogue forward.
Leslie, we did have a question. So we know that University of Minnesota has a very big reputation in kind of interprofessional education. Do you all do much in disability education at the UME level? And if so, are your faculty kind of called upon to be champions for that or to teach that? Or
yeah, there is a tremendous opportunity, and maybe we can connect it again. I don't see any of our leaders in that space on this link currently, but if you're interested, Mike, I think that we could facilitate some dialogue in that and some exchange of ideas. One other thing that could be very helpful is an exchange of visiting professorships. So some formalized way of exchanging information, allowing people to come and give talks in both institutions and bolster and develop more opportunity for dialogue. So that's something we could explore as well.
I don't see any questions in the Q&A or the chat.
So from my perspective, I would very much like to have ongoing, a follow-up discussion. So maybe we can get together on a call in the coming weeks and talk about how to collaborate in this space.
Thank you guys again for a great presentation and giving us a lot of food for thought, I think. And then thank you to all of our attendees today for our grand rounds. Please feel free to reach out to the presenters directly if you have a question that you didn't ask during the presentation. The webinar will be posted soon on our website with a link to our YouTube channel. And as a reminder, please see the chat for information on how to obtain CME credit for today's webinar. At the end of the webinar, you'll see a brief 3-question survey that will pop up on your screen, and we'd appreciate your feedback. We also hope you can join us next month for our grand rounds on Thursday, May 4th at noon Central Time. The presentation will be Assistive Technology After Spinal Cord Injury, How Minnesota's AT Program Can Help. So thank you all for attending. Thank you again to our presenters, and have a great rest of your day.